Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you another amazing topic. Today's guests are Dr. Kelli Wilson and Dr. Nick Rainey, the latter of whom you already know from episode 79. Dr. Wilson is a fellow of our academy. Additionally, in 2019, she started the AAOMPT Pelvic Health Special Interest Group, which is also referred to as a SIG. Dr. Wilson is also the development director at Integrity Rehab and owner of Alcove Education, a continuing education company focused on pelvic health education for both physical therapists and physicians. Dr. Wilson has presented internationally on pelvic health topics and serves as a mentor and instructor for a manual physical therapy fellowship program. Dr. Rainey is the founder of Rainey Pain and Performance and Sierra Vista Headache and TMJ Specialists, both of which are private practices located in Arizona. He is a board-certified orthopedic clinical specialist and a fellow of our academy. In addition, he is a certified cervical and temporomandibular therapist, and he is pelvic health certified through Evidence in Motion. Lastly, Dr. Rainey teaches through Rocky Mountain University of Health Sciences Continuing Education Division. We invited Dr. Wilson and Dr. Rainey to the podcast today for two distinct purposes. First, they recently presented at both last year's 2021 AAOMPT Conference and this year's Combined Sections Meeting at the annual APTA Conference. The title of their presentations was Hidden Contributors to Orthopedic Lumbopelvic Pain, Pelvic Health Examination for All PTs. Second, we have also invited them to the podcast today as a more general introduction to our audience. The reason for this is that in the future, you will hear their voices as co-hosts. Dr. Rainey and Dr. Wilson aren't joining our regular team of interviewers. Instead, they're going to be periodically joining the show as guest hosts representing the AAOMPT Pelvic Health SIG, which we'll link to in the show notes. This means that perhaps several times a year, you'll be hearing from pelvic health specialty interviewers talking to pelvic health specialty guests on topics that relate to orthopedic clinical practice, which I hope you're looking forward to hearing. That long-winded introduction aside, let's avoid any further delay and get to the interview. Dr. Wilson, welcome to the podcast. How are you today?
I'm doing great. Thank you so much for having me.
And Dr. Rainey, a warm welcome to you as well. How are you?
I'm doing outstanding, Stephen. Thanks for having us on.
What a great word. I love that you're doing outstandingly. And let's dive right into the topic at hand. The two of you, and I believe maybe with some assistance from colleagues, gave presentations. We're going to talk about that. You gave presentations on pelvic health, both at the 2021 AAOMPT Conference and then at this year's 2022 CMS Conference. So why did you and your co-presenters want to compile this content and take it both to the AAOMPT and the CSM audiences?
I can take that one. When you're pelvic health trained, you start to see things you didn't before you were pelvic health trained. And the goal is to help people that are not pelvic health trained start to see some of the things that we see. For instance, what drove me to get trained in it is I noticed this subset of people that were not getting better in my clinic, with low back pain, hip pain, pelvic pain, were those that had some type of pelvic floor findings. I started noticing they had dyspareunia or incontinence or constipation, were the common ones. And I realized there was something I was missing. And so that's when I went to get the training. And our hope is that we can help people start to recognize those people and start to increase their knowledge base so they can recognize those people and they can get them better like we've started being able to.
I think that's a really noble thing to try and accomplish. And of course, our profession is going to benefit from that type of effort. And speaking of your efforts, as somebody who reviewed the material that you presented, one of the features of your work that really stood out to me was the decision tree created by the AAOMPT Pelvic Health SIG. Tell us about that decision tree. What is it and how should it be used clinically?
Yeah, so the decision tree can be used a few different ways. I'll give an overview of what it is, but there's two parts. There's a top section and a bottom section. First section has to do with urinary and bowel functions. So it's going to be asking those questions. And then the second is about symptoms, particularly a lot of pain symptoms. Three ways that this could be used. One is that it could be given to everybody that walks through the door in the clinic. What that's going to do, obviously, that this is not going to be, we're asking about urinary and bowel and symptoms in the lumbo hip pelvic area is going to be more pertinent for those people walking in with those complaints. But if you want to use it as a screen to find out how many people you may be missing, offer them, if they're coming in for their ankle pain or their neck pain or whatnot, could this be something that could be related to there for sure? But maybe it's something that you could advertise to them as another episode of care, then bring up a conversation that, hey, we can also help you with this. Another way it could be used is with those people that are coming in with those complaints specifically. For instance, one of the questions in the bottom section is about, do you have low back pain? And they're marking yes. So if they're coming in with that complaint, they're surely going to be marking that one. And so but then they're also they may be marking other sections on there as well. And it's a good reminder to you that, pelvic floor, pelvic health could be related for this person. Or you could just use all this verbally. If you don't want to hand them the sheet, feel like they have too much paperwork or you forgot to give it to them, looking through those things gives you other questions to hit in your subjective to make sure you're not missing this. What we all find in clinical practice is if we have standards, routine things that we do, it helps us not to miss things. If we have to rethink it every time, it makes it challenging. So this is hoping to help make it systematic so we're not missing pelvic health aspects of things that people are coming in with that they didn't know had a pelvic health component and that maybe previously you hadn't recognized that there could be a pelvic health component.
And I would like to follow up with what Nick was saying. There are 2 articles cited for this decision tree. This is not a validated screening tool. We cannot go through all the parameters to back up a funded, validated study. However, we did try to support this screening tool with citations and research. And there's 2 studies cited on this. And what's interesting about both of them is that they found, for one was DUFOR, which was the association between lumbopelvic pain and pelvic floor dysfunction in women. And they analyzed women coming into the outpatient physical therapy setting. And out of those women, they found that 95.3% had pelvic floor dysfunction. And they were coming to this outpatient physical therapy setting for low back pain. So that is a very, very high correlation that we're looking at. And so that is why it's important to ask about low back pain. There can be easily a pelvic floor dysfunction that you need to cipher through.
Excellent. Thank you for that information. And we'll be sure in the show notes to link to the 2 articles that you just referenced. And as a follow-up question on that, for the audience's purposes, is this the type of decision tree that's available widely? Can anyone access this? Or do you have to have some sort of special permission or maybe a membership to find what the decision tree is and how to use it in the clinic?
You can easily access this tool. It's on the AAOMPT.org website under the Pelvic Health SIG tab, and it's a free downloadable PDF.
Excellent. Thank you for that information. And we'll also link to that in the show notes. And if we can continue forward with the orthopedic theme, since of course we're an orthopedic-based academy, can you speak to us a little bit about how pelvic health relates specifically to low back pain and hip pain? And of course, these are regions that pretty much every physical therapist across the globe has evaluated and treated. But as you've already alluded to, maybe they're missing that pelvic health component that is, or maybe I should say, can be linked to the hips and low back.
This is a conversation that's a lot longer than just this, 1 hour podcast, but for sure, yes, part of the mission of the Pelvic Health SIG was to discuss and normalize the discussion of pelvic health. Because when we talk about pelvic health or the term pelvic floor, sometimes that can be very polarizing in our field. And we get this hard set imagery of, everything defined within the pelvis. And that's almost kind of like what we think of as no man's land, that no one can address that. But as orthopedic manual PTs, we are always looking at, with our further education, with our fellowship training, we are looking at the whole picture when treating our MSK conditions. Thinking of pelvic health, the term I utilize lumbopelvic anatomically, which signifies the lumbar, the pelvis, and the hips, because the pelvis is just the highway between, the upper body and the lower body and everything in between. So we're not just looking at how this isolated pelvis is moving, but also how things correlate above and below from our feet to our head. So it's very expansive and it needs to be addressed and looked at from for a comprehensive pelvic floor physical therapist. But let's go back to your question about, how does the pelvic health relate to low back and hips? Well, the pelvic floor muscles are comprised of 14 to 17 muscles, depending on which textbook you're looking at. And the pelvic floor muscles are our supportive platform, that are shaped like a hammock in our pelvis. And they directly insert into the coccyx region, the coccyx bone, right? Whether directly or indirectly. And so if I break this down orthopedically, if the pelvic floor muscles are having an increased tone or they're overactive or underactive, that's going to be an adverse situation for our whole spine all the way up. So if you're thinking about the hammock pulling excessively posteriorly, if we're thinking about mechanically on the coccyx and sacrum, that's going to make excessive force along the sacrum and change all the way up the chain. So, overactivity of the pelvic floor muscles easily can be correlated with, like we were just discussing in the previous question about the decision tree and the correlation with low back pain. That's why they tie in so greatly together. But if we look also at the hip easily, if we're going back to that hammock, there are fascial components that share from the pelvic floor muscles to the obturator internus, which is a hip external rotator, correct? There is a high tendinous junction shared between the pelvic floor muscles and the obturator internus. And we know that the obturator internus is a big player with hip stabilization and femoral movement. It's a primary driver for hip extension and hip external rotation and hip abduction. And so hip obturator internus and pelvic floor muscles really play off of each other. And they can be kind of like I don't know if evil stepbrothers, but they are sisters and brothers, and they feed off of each other. So if one's not engaging properly, the other one's not as well, and vice versa. So there has been studies by Tuttle, is a great author. They support studies with females that have had weakness to their hip external rotators, also crosses over with the weakness to the pelvic floor muscles. So they found that strengthening deep hip rotators, including the obturator internus, improves pelvic floor muscle strength. Overseeing the hip definitely is an important factor for pelvic floor optimization and vice versa. Then we can also look at how the pelvic floor muscles look up the chain with the low back. So our pelvic floor muscles are a base of our pelvis, right? But they're also the base for our pressure system. And I think there has been a lot of evolution, a lot of research on us looking at breathing patterns and how our pressure system plays off of each other. So we know that the diaphragm is very important with our overall function, and the efficiency of the diaphragm moving properly is synergistic with the pelvic floor muscles. And so these easily go hand in hand. So if there's something awry in that system, then the diaphragm's not working properly, the pelvic floor muscles aren't working properly, there's overactivity to the paraspinals, and perhaps there's decreased activation of the abdominal muscles. This pressure system needs to work cohesively to make an overall body management. And if there's not something working properly, there's going to be confounding issues, possibly. I mean, that can include low back pain, a musculoskeletal condition, inguinal hernias, umbilical hernias, breakdown of the back, degeneration. So it can cause a multi-system approach, but I hope I answered your question, Stephen. It can be very overwhelming and involve a lot of prospect of everything.
I'd like to discuss just a little bit about the terms pelvic health and pelvic floor. Pelvic health is it's basically everything from the diaphragm down to the pelvic floor. And it can encompass conditions like constipation, endometriosis, any prostate issues, other bowel issues, urinary issues. That all is encompassed in pelvic health, where pelvic floor is just a little bit more specific, and we're talking primarily about the muscles that are down there, nerves as well, but a lot of times we're talking about muscles in the pelvic floor. And if you look at research, a lot of times they'll address specific areas of, is how is constipation related to fibromyalgia or low back pain? What are the referral patterns for the pelvic floor? Is it just in the pelvis? Is it out to the hip? Is it just to the back? And those things can play off of each other. For instance, something like interstitial cystitis. There's some urogynecologists may talk about it just as a pelvic floor issue. Not in every case, but sometimes it may just be overactive pelvic floor that could be the primary driver of the interstitial cystitis diagnosis. And so there's a back and forth between the health of everything between, like the viscera, between the diaphragm on down and the pelvic floor. But pelvic health encompasses a little bit of everything there. And pelvic floor, more specifically, the muscles that, between the pubic bone and the coccyx bone, including the obturator internus.
Well, thank you both for those answers. That was very informative and thorough. And as you alluded to, it's a really huge topic that we're not going to fully tackle here today, but that clearly demonstrates the interconnectedness of these regions, the low back, the pelvis, the hips. And I think my favorite little tidbit from all of that is the quote about normalizing the conversation about pelvic health. It is, in my experience, and also clearly in yours, it's that conversation that sometimes people don't want to talk about or don't talk about. And it's really inefficient of us and inappropriate of us if we can't have a thorough, professional, and targeted conversation with our patients about an entire topic that is, of course, intermingled with orthopedics, which is what all of us do. And building off that point, one of the themes that I noticed from your presentation is that you did a really good job talking about how even before we get to the objective examination, you can use subjective interviews to try and tell the difference between somebody with an overactive pelvic floor versus somebody with an underactive pelvic floor. Can you talk to us about how that's accomplished and how an expert orthopedic clinician can use that verbal interaction to try and steer their mindset towards either this type of pelvic health diagnosis or that type of pelvic health diagnosis?
Yes, definitely. So in the subjective interview, what I'm looking for, a few different things. One is if there's pain. Now, typically, if somebody's coming into our clinic, it's pain related, right? If somebody's just coming in for urinary incontinence, they're probably seeing a pelvic health specialist because that's where they're geared for. I think all orthopedic therapists should be able to treat stress urinary incontinence. But what we're really looking at here is the person coming in, sitting in your clinic with, low back pain, SI joint pain, pain in the lumbopelvic hip region. That is typically an overactive pelvic floor presentation, if the pelvic floor is involved. And I'm not saying everybody with, those presentations has an overactive pelvic floor. However, oftentimes that is a component of it. Now, does that mean we always have to treat the pelvic floor to get it better? No, that doesn't. We can have an effect on the pelvic floor even when we're not directly or purposefully targeting it. We've all affected the pelvic floor before without purposefully targeting it. But with underactive, typically those are your more classic stress urinary incontinence, where it's just not strong enough or coordinated enough. Often there's not a pain presentation with it. Now, does that mean that somebody can't have stress urinary incontinence and a pain presentation? Obviously not. And that does co-occur. But oftentimes, if there's an overactive component, if we treat that overactive component, it can help that pain. Where if there's an underactive component, then it's not as directly correlated to the pain. And we could treat that and they could still remain in pain, even while if we're just helping their stress urinary incontinence.
Thank you for that response. And if I could bring up what is, I suppose, often the single topic that any physical therapist can talk about when it comes to pelvic health, and quite frankly, most patients as well, and that is Kegel exercises. Talk to us about whether or not we should implement Kegel exercises or avoid them, and perhaps give us a little bit of context in what is a Kegel exercise and how useful are they clinically?
Well, this is the age-old question, isn't it? I think that as a field, we can do a lot better than just a Kegel exercise. And to answer your question, a Kegel exercise is a concentric contraction of the pelvic floor muscles. A lot of times people will overcompensate and pull in other muscles like gluteal muscles or adductors. And so it can kind of feed into that elevated tone to the region. So like Nick was saying, the majority of our patients that are coming in to the orthopedic setting, we are seeing them for pain. So I wouldn't say you can immediately deduce that they're going to be in a overactive state, but more than likely is probably going to be elevated and tight and guarded, because when we're in pain, what do? We kind of guard, we tighten, we hold things in. Even what's an interesting side fact for pelvic floor dysfunction, a very high comorbidity with pelvic floor dysfunction is TMD issues, so jaw pain. So when you're guarding at the pelvic floor, the jaw is guarding and grinding because you're having this constant pain. So they can feed off of each other. But to go back to the Kegel, the pelvic floor muscles can concentrically contract, but they should also be able to relax back to baseline. So they should be able to go back into that hammock position. I think of it as a fruit net, right? That you put bananas in. Because when you put bananas in the fruit net, they lengthen, that net lengthens down. That would be an eccentric contraction of the pelvic floor muscles. So they should be able to actively lengthen, or we think of it as actively relaxing. And then when you take the bananas out, they have this passive recoil where they go back up to neutral. So think about that hammock. It can concentrically elevate, right, and tighten and shorten the muscles. It should be able to relax back down to baseline once you stop trying to squeeze. Because sometimes in our population, we see when they squeeze up and lift, they stay there. They stay in that concentric placement without properly relaxing back down to baseline. And then we should also be able to actively lengthen and drop down below that baseline. So the pelvic floor muscles need to have this certain amount of dexterity and fluidity to allow for proper motility, ultimately, because the pelvis, although is not having this exceptional amount of, extensibility, right? It's not lengthening like the bicep muscle in our elbow, that our elbow flexes so much. There's not as much movement there, but if the muscle goes up into this guarded state and stays frozen, then that's going to cause reduced blood flow to that area. And the pelvis, we know, is highly, highly populated, not only with just nerves, muscles. It's an interesting castle for our autonomic nervous system. There's a lot of visceral organs sitting in there. So if you have loss of blood flow, you're going to get autonomic irregularity. You could have abnormal vagal nerve input, let alone just the, hypertonicity and ischemia at the muscles and nerves and even lymph. So we want the muscles to move fluid, right? So that's why giving and prescribing a Kegel could be counterintuitive and adverse to our patient population because we're feeding into the dysfunction. We're feeding into that elevated tone. So our job is to teach the patient on how to, ultimately the bottom line is to relax. So we want the muscle to be able to lengthen on its own. And so to answer your question again, as far as prescription is concerned, sometimes just getting the patient to breathe properly can have an influence on the pelvic floor muscles, because ultimately it's not so much about a strengthening program for the pelvic floor muscles. It's actually about getting that dexterity and then allowing to lengthen and relax to be able to get blood flow to that area and make the muscles ultimately more efficient and be able to contract and relax properly. So looking at breathing, making sure they're breathing at a 360-degree movement, their ribs are properly moving, is going to help with pelvic floor muscle mobility without the patient having to hyper-focus on what's happening at their pelvic floor muscles. And then, for an orthopedic therapist, there's an easy, validated external test that you can do for coccygeal movement. So you can easily palpate the muscles. You can easily palpate for pelvic floor muscle activation by palpating the posterior coccyx, but not the tip of the coccyx. You want to palpate probably around the inferior margin of the sacrum, like at the coccygeal junction. And what you can do is you can have the patient activate their pelvic floor muscles and try to relax to see if they can even do it. And this study has shown there's a slight movement of the coccyx, then the patient is able to properly contract and relax their pelvic floor muscles. And so this is an easy test for any orthopedic therapist to easily put their hands on the posterior aspect of the coccyx and see if there is equalized movement, contracting and relaxing. And so as a side note, that's why also, even to get prescribed Kegel exercises, if you have a patient with a forward flex coccyx dysfunction, that might be problematic because you don't want to give a Kegel to a coccyx that's already moved forward, correct? That's going to feed back into that dysfunction and cause a proliferating coccyx movement forward. So just as a little side note, anecdotal clinical input from my perspective. I think I answered your question, Stephen.
Yes, you most certainly did. And thank you for that excellent information. And I know you've already started to move into this topic area, but more specifically, for those of us that don't currently provide physical examination of the pelvis, or perhaps who provide limited examination of the pelvis, can you provide for us a few examples of pelvic-specific examination techniques that any physical therapist can use when trying to determine if the pelvic floor has a current problem that we should address?
Yes, great question. In addition to that coccygeal movement test that you can do externally, there is validated studies to support palpatory tenderness is often associated with increased resting tone and the decreased ability to relax. So that's just the muscles being tender to palpate. So just remember your simplified mapping anatomically, right? So, we easily palpate the ischial tuberosity commonly with our orthopedic patients, right? For, insertional hamstring tendinopathy, sciatic nerve pain, and medial glute, in the glute region. Anything that's medial to the ischial tuberosity would be more pudendal nerve and also where the pelvic floor muscles are populated. So if you move your palpatory hand just medial to the ischial tuberosity, you're going to be in the vicinity of the pelvic floor muscles. So if there is tenderness there and you're analyzing symmetry from the right and the left, if there's a variance on tenderness to palpation and it is present, then that has been shown to be highly correlated with a pelvic floor muscle dysfunction and something that possibly potentially needs to be addressed because tenderness to palpation is equally correlated with increased tension or overactivity. So that would be something that you would need to address. You could do myofascial releases. You don't have to do the deep myofascial release. You can easily prescribe self-mobilizations for the patients. Another thing too is that as a side note, a patient can palpate themselves. You can have the patient put their fingers and feel, inside, around their sit bone and feel that there's tenderness to palpation. So it can be a self-directed examination as well.
Excellent. Thank you for that wonderful addition. And if we could just zoom out to the big picture that, quite frankly, is the most important thing for all of the people that have a stake in physical therapy. That's us, that's patients, that's insurance providers and payers. What type of results are you getting clinically when you're performing external evaluations, when you're providing management of pelvic floor dysfunction? And I emphasize the word external because, a provider like me isn't trained to do an internal pelvic floor exam. It's not something I'm going to do clinically. And I want to know the nitty-gritty answer of, if I learn these techniques, if I become more competent with this topic, can I get good pelvic floor outcomes or good pelvic health outcomes when I'm doing purely an external evaluation and management approach?
That question makes me have to self-reflect. I sure hope so, because that's primarily what I do. I am trained to do internal evaluations. I don't remember the last one that I did. It's probably been over a year. When I did them more often is when I got more specific pelvic health referrals. So if they came in they're in there just for incontinence. They're in for, where the urinary or fecal incontinence. The reason they came into the clinic was for like painful sex, dyspareunia. It was those type of scenarios where I would more apt to be going right to an internal evaluation. When I'm not getting those, it's mostly, low back pain, hip pain, SI joint pain, in that region that we're all getting referrals. I don't remember the last time I did an internal evaluation, so I hope that the results are good. I use, what Kelli talked about. I definitely hit medial to the ischial tuberosity, so I can evaluate when they breathe. Does the pelvic floor drop? When they breathe in, when they breathe out, does it rise up? How does the abdomen feel? I'll do a lot of palpation of the abdomen. A lot of times when the pelvic floor is painful or overactive, that the abdomen is as well. And sometimes I'll just test out, how does a pelvic floor relaxation exercise, whether it be the drops like Kelli talked about, or I have them do a happy baby stretch. If those feel really good and it helps their pain, well, I'm going to have them do more of it, right? That's what we all do. We have them test something out. If it feels better, we say do more of that at home. So there's a lot that we can do in that area. And just as the pelvic floor refers up to the low back and hips, treating the low back and hips can also help the pelvic floor. We just want to make sure that we have enough objective measures that we can take and subjective measures, that we can ask them about to make sure that we're hitting it all. We're not leaving a component, and we're not just addressing what we're comfortable addressing. We have a number of things that we're asking about, and we're making sure what we're doing is affecting it. Sometimes I'll treat the low back and it will help the pelvic floor. Sometimes I'll do something more pelvic floor specific, often obturator internus. Obturator internus is one that we can all work on. It's an external rotator. I've worked on that, and then I go back up to the low back, and it's less tender to palpate. And so there's that back and forth play. So I sure hope that I'm getting good results. It seems like we are. We track our photo scores. We're above average, so that's a good thing for us. So hopefully others can do the same thing as what I've done here.
I would like to support what Nick said and say you can certainly get a sufficient examination and provide an appropriate exercise and self-management prescription with external evaluation. Part of our presentation at CSM and the AAOMPT conference was breaking down some case studies and looking at some confounding presentations. And so I, for example, had a patient that was an active duty soldier. He came to me with pelvic health diagnoses on the pad, including erectile dysfunction, inguinal groin pain, testicular pain. But he also had a really involved history with labral tear, labral pathology. He had surgery on his lumbar spine. He was only 33, I think, or 35. But what was interesting is that I was leaving to go get surgery on myself. I was undergoing a surgery where I was going to be out of work for a couple weeks. And so I was unable, I'm the only pelvic floor therapist at my location. And so I was not able to treat him for, I think, about 3 weeks. And so I wanted him to work with my colleague, an orthopedic physical therapist. And that's what he did. I was able just to prescribe pelvic floor drops to this patient because he did have overactivity. But when I came back after 3 weeks, a lot of his symptoms, his urinary, his sexual dysfunction, had actually resolved. Almost greater than 90%, just with treatment focused on lumbar spine and hip. And so that had nothing to do with me. And that had no internal assessment. Everything was external. And so that's what really excited us as colleagues with the pelvic special interest group. And that's why we have been working on a case series and have exciting news. We just yesterday got accepted and we're undergoing edits. We're working on a case series to be published with the Journal of Pelvic Health, breaking down 4 different really involved patients and how they showed benefit and had great outcome. I think 3 out of 4 did not have any internal treatment. And so this is going to help gain confidence for the orthopedic therapist that you guys are actually making changes to the pelvic floor without even realizing it. And we just want to hone in that skill a little bit more, knowledge, to really pull it together and make you stronger in the clinic. And so we're real excited about that.
Excellent. Thank you very much for that response. And if we could just take that content one step further, it sounds like you're saying, of course, that externally, your average orthopedic physical therapist can do a good job when it comes to evaluating and treating the pelvic floor and pelvic health in general. But under what circumstances can we say, for example, I've exhausted my ability in this instance and I need to refer out to a more highly specialized or qualified physical therapist that can perhaps do more than what I'm able to provide?
I really like that question, Stephen. That's obviously, really gets to the nitty gritty of what do we do when we're with the patient in front of us, right? What point do we say, oh, this is beyond me, I need to refer out? Well, let me start with when it's not needed to refer. It's not needed just because they need to talk about peeing, pooping, sex, penises, vaginas. That is not the reason just to refer there, where it's easy to say, oh, that's outside my field. All that is stuff that we should be able to address. And it's not sufficient to say any bowel bladder changes and hope they say no and then move on. But any of those things, we're a doctoring profession. We should be able to address and talk about those things. Where we do need to refer is if the person needs more knowledge or skills than what we have. So knowledge, maybe they don't need an internal exam. You're trying. You've asked about, all the pelvic health things. Again, those things that we should be able to address. But they're not making the changes that you think they ought to, whether it be in, dyspareunia or constipation or incontinence, or maybe it's with their low back pain or their hip pain that they're not making the changes that you think and you're stuck. That's a lack of knowledge. Send it to somebody else for another set of eyes, somebody who's more specifically trained to be able to go a little bit deeper with that, or they have another skill set that you don't. But just because they mention those things, we don't need to totally avoid it. And it's easy not to ask because we don't know. We think we won't know what to do when they give us those answers. We can ask, and maybe we don't know specifically, but we can start to track. We can treat with our normal low back techniques, our normal hip techniques. We add a little bit of pelvic floor coordination and breathing techniques, obturator internist, stretching, strengthening. Give them some home tips for soft tissue work of the pelvic floor. And if they make progress, great. If they don't and they plateau, or maybe they make it with their low back, but then they're like, I wish that my incontinence was better, my constipation was better, or whatever it may be, and you're stuck, that's when you refer out. But just because they have those issues, we don't need to just toss everybody to somebody who's more specifically trained there.
That was a great answer. Thank you very much. And this information, I would like to say, has been all super informative and helpful. It's my general understanding that all of us need to become a little bit more acquainted with pelvic health evaluation and management. So I think this is going to be a very valuable episode for our audience. And as we're closing things out with this conversation, I'd like to note that we have more of these conversations to look forward to. As I mentioned earlier, the two of you are going to come back in the role of being hosts of future episodes. And if we could just take a minute and talk about that, what type of information or topics or conversations can our audience look forward to hearing from not only just the two of you, but in general from the AAOMPT Pelvic Health Special Interest Group?
We are really excited just to be discussing the topic of pelvic health here. And so thank you so much for inviting us and allowing us to participate with the AAOMPT podcast. We look forward to really deep diving into the literature, looking at research studies, and really helping expand, how the pelvic floor ties in with hip pathology, lumbar spine pathology. We can reach even to ankle sprains. The sky is the limit, Stephen. So we're looking forward to really evaluating the research, the literature, and bringing hopefully clinical tools for our listeners to have in their toolbox.
Yeah, I think this is better than I do, Stephen, probably the second, third, maybe fourth podcast on pelvic health that AAOMPT's done. And, I wish we could say, oh, you listen to one podcast or even a few podcasts, you're going to be changing your clinical practice. But hopefully as we build on this somewhat regularly, that people start to make a little bit of changes. They realize, hey, I could have asked that question here, try that technique here, and they start to build. And little by little, there start to be a little bit of change in clinical practice just by listening to the podcast that you do so well on.
Well, thank you for those kind words. And if I could reach back into a theme that was mentioned earlier, part of what I think is going to happen with this project is that we're going to begin or perhaps continue to normalize the conversation about pelvic health. It is, as we've already said, sometimes that no-go region that your average orthopedic physical therapist does not talk about, does not evaluate, does not manage. And quite frankly, that's unacceptable. The most basic truth of our profession is that we need to do the things that our patients need us to do. And our patients need us to be experts, not just in back pain, not just in hip pain, but also in how to handle pelvic health dysfunction. And hopefully this podcast is going to, in the future, be one small extension of how people can begin to become more confident, more capable in this realm. That point having been made, Dr. Wilson, Dr. Rainey, thank you not only for all the work that you do in this very important part of the orthopedic world, but also thank you for bringing this content to our podcast and to our academy. And that's, of course, not only a reference to today, but all of the episodes that we're going to generate in the future. And I very much personally look forward to hearing them. And I know that our audience is going to benefit as well.
Well, thank you so much, Stephen. And I certainly look forward to it.
Yeah, I agree. This was a lot of fun, Stephen. Thanks a lot for having us. I always enjoy talking physical therapy, pelvic health, orthopedics, and pain.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.AAOMPT.org, which you can find in the show notes.